I'll make you move like your boots are on fire. I'll make you jump like you touched a live wire. Ain't no sitting down when I get in the zone. Just give me my crown, let the king take his throne.
Happy Friday, everybody. A little bit of clouds here in normally sunny Arizona. We got another week, another day of procedures. Today we have one procedure. We have a patient who is going to get some PRP and some peptide injections for shoulder and low back pain. Yesterday we had a patient that we drained a Baker cyst. We flushed out the knee to clear out some of the inflammatory stuff that's in there, and also put a little bit of peptides in the knee as a priming treatment for her stem cell procedure that's going to be happening most likely next week. So those are the procedures that we had this week, and here. Happy Friday. All right, everybody, we just finished up another Friday here, Fridays at RP. We had several procedures today. We had one procedure yesterday. Let's dive into some of our recap. So yesterday we had a patient who, in the next coming weeks, we are going to be doing an adipose and bone marrow derived stem cell treatment for her knee osteoarthritis. However, because she has some pretty significant knee joint effusion and a Baker cyst, which is basically going to be that effusion kicking out the backside of the knee, we wanted to make sure that we got out a lot of the inflammatory crap that is going to be in her knee prior to going in with our interventional procedures. And so because of that, we drained the knee, we drained the Baker cyst, and then we also put some hyaluronic acid back into the knee joint. Because she has the osteoarthritis, we still want to get a little bit of hyaluronic acid in there to help with that cushioning, when we'll also include the hyaluronic acid in with her stem cell treatment that's going to be in the next few weeks. But that is basically what we wanted to do. We wanted to get a lot of the inflammatory MMPs, TNF alpha, the different cytokines in there that are contributing to the pain, contributing to some of the inflammation and swelling, drain that out, flush out the actual joint, and then put in some hyaluronic acid. So that was yesterday's procedure. Now today we ended up having like 5 procedures, but I'm gonna really cover just a few of them. So our first case of the day was a PRP treatment for a gentleman who has had some shoulder pain while golfing. And then he's also got some kind of low back stiffness in the morning that doesn't really bother him day to day. It's more of that, just his back feels stiff in the morning and kind of lasts about 30 minutes, so we don't suspect there's an inflammatory disease going on there. And so our exam for the shoulder came up with a few things. One, it was pretty clear and evident that there was going to be some rotator cuff tendinosis. Now, because of the overuse from playing a lot of golf, he actually had tendinosis in 3 of the 4 rotator cuff muscles. So basically the supraspinatus, the infraspinatus, and then the subscapularis. All of those were painful on our orthopedic testing and recreated some of his pain. But under ultrasound evaluation during our first appointment with him, we did also see some tendinopathy in those tendon and theses as they're attaching onto bone. And so that kind of corroborates, the imaging corroborates with our history. And so that's one of the things that we decided to treat. Now, the other thing that came up was some positive orthopedic testing for some bicipital tendinitis. Now, when we actually went and looked under ultrasound during our ultrasound examination, we saw that there's actually bicipital tendinosis, which is going to be inflammation and fluid collection around the biceps tendon from an inflammatory process. And so with our injections, we ended up putting a high dose of platelet-rich plasma in and around that biceps tendon in order to help calm down that inflammation. And so that way it can help heal and therefore be less painful. And then lastly, for the shoulder, he did have some generalized neurogenic inflammation of some of the main nerves that are going to feed that area. Suprascapular nerve and the axillary nerve being the biggest ones. And so we did an axillary nerve hydrodissection in the quadrangular space. We did a suprascapular nerve hydrodissection in the spinal glenoid and the suprascapular notch. And we also rounded it out with an anterior subdeltoid fascial plane hydrodissection. That is a newer procedure for us here, where we are basically going between the rotator interval and the deltoid muscle and opening up that fascial plane with the fluid, bathing a lot of those cutaneous nerves that are going to innervate supraspinatus, subscapularis, the biceps tendon, those types of things. And so super excited for that. Now on his low back pain, physical exam was unremarkable for most things. Some mild pain when we were testing the facet joints, which is kind of consistent with the sensation of stiffness in the morning, because that is more common with osteoarthritis. And the facet joints is where we get osteoarthritis. And so under ultrasound guidance, we injected into the facet joint, around the facet joint capsule, as well as into the multifidi muscles, because the multifidi muscles are big stabilizers for the low back and implicated in a lot of cases of chronic low back pain. That was our first procedure of the day. Now our second procedure was an acute case where we had a patient come in with an acute shoulder pain, and this has been going on now for about 2 days. The patient doesn't really have any preceding events. It's not like he had a fall, a car accident, anything like that. He has been playing golf a lot more. He's been doing a lot more movements at home, in the gym, just a bunch of these different little factors, but he's now at the point where he really has very limited range of motion. So going forward with foreflexion, he can only go about here. Abduction, he's only about here. Extension is a little bit better. He can get back here. External rotation is very painful and he can't do much. So we obviously aren't able to do most of the physical exams we want to, because we can't even get him into the position. But one of the things that came up with the physical exam we could do was a list of differential diagnoses. Our list initially were things such as adhesive capsulitis, so frozen shoulder, where we were getting a constriction of the capsule around the actual shoulder joint. We could have had an intra-articular loose body. This patient used to play professional football, and so it's possible that he has cartilage damage in that area, some osteophyte buildup, things like that, where something might have dislodged and now he had a loose body inside the joint. And then we also had nerve entrapments. We have seen this in the past where patients have had really bad impingement of the axillary nerve that result in a severe loss of range of motion. And so we decided to do some point of care ultrasound on him today to kind of see, hey, what do we got going on? Let's check out supraspinatus, let's check out biceps, let's check out all these different areas that could be contributing to his pain. And what we found is more than likely a tear in his biceps tendon, technically the biceps muscle at the myotendinous junction or the musculotendinous junction, which was evidenced by some discontinuity in the fibers, a collection of fluid, and then what looks like basically a stump, which is some of the retracted fibers of the biceps muscle and the tendon. As they come through, they make this little stump. And so today, for pain management, we talked with the patient. We obviously want to do imaging. We want to get an MRI to determine how severe the injury actually is, the tear. But for pain management, we did very similar procedures as our first case. So we did a suprascapular nerve block, and then we did an anterior subdeltoid fascial plane hydrodissection, but we used a local anesthetic solution. Basically, our goal in this situation was to just give the patient some relief, because he hasn't been able to sleep because of the intense pain that he's been in. And so we did nerve blocks, even though we know that those are going to wear off after kind of 8 to 12 hours with the ropivacaine that we used. But we wanted to give the patient some relief so that he was able to be a little bit more comfortable through the rest of the day and the night, and then hopefully we can start figuring out next steps in terms of, is this a surgical referral? Are there different things that we can do on the regenerative injection side? How do we play this out? As a little side note, some of the other things that we did for him was BPC 157, a phenomenal peptide that we use commonly in our patients. We both have acute and chronic injuries. I personally believe, and if you look at a lot of the research, I believe that BPC 157 works the absolute best in acute injuries. And so we had him start on a loading dose of 500 micrograms twice a day. That, along with some topical creams, some herbs to help pain, and then a pain script because he's in quite a bit of pain, and there's a time and a place for those types of medications. So we're really kind of coming at this from an acute care standpoint. How can we manage pain? How can we figure out next steps? But hopefully we are able to help this patient, whether that is getting him in with the right surgeon or that's our regenerative injection methods. We had a few other procedures today, but one of them really pisses me off. Not the procedure, just why this patient ended up having a procedure with us, because the insurance system sucks. So I'm gonna save that for another time though, because it is late here on a Friday and I wanna get home. So thank you so much for watching. I really appreciate it. Please leave a comment on the things that you are enjoying from these episodes, things that you would like to see more of, and we'll see you next time.